And before we start, just to remind you the housekeeping rules, please make sure to rename yourself with a Zoom name similar to what should appear in your participation certificate. And towards the end of the lecture, a link will be shared in the chat box. Please fill out the provided form. Note that attending the lecture for a minimum of 30 minutes and completing this form are necessary to obtain the certificate. The certificate will be sent to you via email within 1 week. Please keep your microphones muted and videos off throughout the session. If you have any questions, kindly type them in the chat box. They will be addressed later. Welcome all of you for another CPD activity organized by the Sri Lanka College of Specialist Family Physicians. Tonight, our resource person is Dr. Neranga Pravin Samaratunge. He is the acting consultant cardiologist working at Base Hospital Puttalam, and he has obtained his MBBS MD and also certified by the American College of Cardiology and the European Society of Cardiology. So without any further ado, sir, over to you to talk about mastering the evaluation of chest pain from symptom to solution. Sir, over to you.
Okay, thank you very much for giving me the opportunity for Sri Lanka College of Specialist Family Physicians. So today we are going to discuss about how to evaluate the chest pain. Okay, so first we'll go through with some cases. So this is a 60 years old patient coming with OPD as he want to check his blood pressure. He's a farmer who cycles around 10 kilometers daily without any difficulty and came to the hospital when he just came to the town by cycling, after cycling, and just to check the blood pressure. So blood pressure was higher side for last few months, around 160/90, and GP has told to measure his blood pressure again. And he has also undergone salt reduction. So at the OPD, he is clinically well and blood pressure 164/96, pulse rate 60, and ECG was being done. So any comment you have? Hopefully you can type if you are, I think you are muted, you can type. So what do you see in the ECG? So I will discuss it later. So the admitting officer got panicked and asked to admit and start treatment for myocardial infarction, and stat doses of enoxaparin is being ordered. But the patient denies any chest pain and refuses to admit as he doesn't have any problem. And last week he has a good exercise, like he actually climbed Adam's Peak too. So what do you think? We're going to admit and treat as ACS, admit, do troponin. If positive, treat as ACS, inpatient cardiology opinion, discharge without any medication or follow-up, start antihypertensive, preferably a polypill, and discharge the patient since there's something is abnormal but can't be serious because he's asymptomatic and outpatient cardiology is arranged. So what do you think around from 5? Yes, correctly said, it's LBB. Out of these 5 options, what is the best option you think? Okay, there's someone saying admit and treat ACS. And there's some saying 2, admit to troponin if positive, treat as ACS. Okay. Most answers are 2. Yeah, you see a lot of 2. Oh, yeah, most are saying 2. Yeah, so this is actually, so this is also showing, and someone is, Dr. Mendes is saying 5. Good. So this is just to highlight that this is a scenario I have came across several times. A lot of times the same situation happen repeated. Some patient come with a cataract surgery or something, which is completely well, but just incidental finding. So this is an incidental finding of LVB. So if you take this context, so that is I want to highlight the history. So So patient presentation. So if you take the presentation, this patient is completely well, asymptomatic patient, just coming for the blood hypertension. So you can see the patient has a good exercise tolerance. So there's nothing to suspect there's ACS going on. So the correct answer is start antihypertensive, because the blood pressure is throughout our last 3 to 4 months, like it was being higher side. So we had to treat for hypertension and preferably a polypill. Although this ECG is abnormal, so LBB most likely non-ischemic. But because several things give rise to LBB, we have to arrange a cardiac referral. Like infiltrate care, so most likely this is a degenerative change due to non-ischemic LB, but cardiomyopathies, infiltrative cardio diseases, things like that can give rise to LBB. So we have to do outpatient referral, but most likely patient will only need antihypertensive treatment. So if you take a LBB and so if you take this one, so this is a LBB, but if the patient is having acute onset chest pain and patient is obviously having anterior MI, so you can see the reciprocal ST depressions are there, and this hyperacute T waves are on top of Qs. So this is a benign LBB pattern. So there are some slides I will not discuss deeply because of the time constraints, and you don't have to know it that much. So there are called some criteria to diagnose what is ischemic LBB, but usually when you take the clinical history alone, there's nothing to suspect, and the ECG pattern is also not significant. So if I just briefly go to the hypertension, because the case there as a patient is hypertension, obviously. So if you so if the blood pressures are, usually you have to do lifestyle optimization. Then we usually start with the polypill, unless the patient is very elderly patient, like 85 years old, patient having orthostatic hypertension, frail patient, or blood pressure is slightly elevated category, like 120. Normal blood pressure is less than 120/70. Home blood pressure 120/70 to 140/90. It's elevated blood pressure. You can start initial one. Every other patient you need to start a dual therapy. So the things we have are losartan HCT, losartan amlodipine, and telmisartan HCT and valsartan amlodipine. So after that, you have to increase accordingly this guideline. This is actually Sri Lankan, not a guideline as say we have adapted from the European guidelines. Second case, 39-year-old patient is smoking 5 cigarettes per day. Father had MI and died at 42. Mother diabetes, which was diagnosed after pregnancy. Elderly sister had a CABG at 50 years. Brother died at 45. BMI 26, sedentary lifestyle, blood pressure higher side. Patient had left side chest pain with rest and also at the rest, and with exertion also, and lasting for few minutes. And there is no obvious thing which relieve the chest pains. Chest pain sometimes persists even the patient is resting. The resting ECG is normal. Fasting blood sugar 106, cholesterol, total cholesterol 198, LDL 110, triglyceride 160, HDL 38. So we'll go through it later. Okay, the third patient, we have 48 years female, diabetes for 6 years, fasting blood sugar high, there's hypothyroidism, BMI 33, no family history, having exertional dyspnea, not chest pain. Patients are given glycoside, losartan only, and blood pressure is still higher side, and patient has tachycardia. Resting is normal, except the tachycardia. The blood sugar is obviously not controlled. And LDL is not very high, like 110, triglyceride 180. So how do you manage that patient? Yeah, okay. So what things I want to highlight is actually you have to take the patient presentation into the context. So why did the patient come to the hospital? So in the first instance, patient has just not come for chest pain. So very unlikely the patient with acute LBB does not have a chest pain. And taking the scenario, you can just imagine, you can check the picture, the patient's profile, like it's a preferably very fit patient just coming for the ECG change. So you don't have to take the patient's presentation into the account when you diagnose anything. So this is very important. If you take the patient presentation and take the good history, most of the chest pains, unnecessary admissions can be prevented, and you can actually give the correct treatment and without treating unnecessary things. And you have to ask about detail about the presentation. How is the chest onset of chest pain? What are the relieving? Is there radiation? Is there relieving factors, aggravating factors, so on and so. And as past medical history, you are specifically asked about diabetes history, hypertension, dyslipidemia, ischemic heart disease, CKD, and also non-alcoholic fatty liver disease, and smoking history. Family history, especially immediate family members like mother, father, and siblings, and the age of presentation. The male patient coming less than 55 and females coming less than 65 is significant. Premature coronary disease and family history of diabetes, hypertension, or dyslipidemia. And females, you have to ask about the pregnancy-related things like BIH, GDM, any miscarriages, stillbirths, preterm, and etc. Because most of the around more than 50% of the patient with GDM will definitely have diabetes later. So it's very important them to tell regular check at least once a year their blood pressure and blood sugars. So there are risk enhancing factors for risk. So if there's a family history of atherosclerotic cardiovascular disease, there's family history of hypercholesteremia, usually LDL is more than 190, is very significant. So metabolic syndrome is there. So obese patient weighs more than 80 in females, more than 19 males, and that's low LDL, less than 14 men and less than 15 females, high blood pressure, 149, 135, 85, and elevated triglyceride more than 150. You have to, and fasting blood sugar more than 100. So you have to, the patient has metabolic syndrome, there's a high risk of developing heart disease. And the CKD and other inflammatory diseases like rheumatoid arthritis, premature menopause, high risk ethnicity. We all are in South Asian, so we have high risk. And there's other lipid profile, lipid like lipoprotein A, LP, lipoB, and elevated high sensitivity CRP, etc. So these will risk enhance. So if you take after the history, you have to ask about these risk enhancing features are there. And the females, you have to ask about the GDM, PH, and preeclampsia, etc. As I have discussed earlier. And other things like socio-economic deprivation, severe mental illness, depression, HIV also increase the risk. Right. So this is a patient with 45 years old, hypertension, but not on regular patient follow. Coming with sudden onset chest pain with back pain. Lungs clear, there's murmur, auscultation, TROP is positive, and patient is managed as AC. This is a true patient, which obviously the ECG is not the patient, but the similar type of ECG. The blood pressure 230 by 100, and the pulse rate is around 188. Any idea? What do you think about this patient and the ECG? Yeah, there's obviously the correct. Someone has answered. LVH strain pattern is there. So these are no ST elevation. These are left ventricular strain pattern. You can see the one AVL and lateral leads have ST dips also. These are due to LV left ventricular strain due to hypertension, uncontrolled hypertension. So why do you think the patient is having chest pain? Yeah, aortic dissection. Yeah, it's correct. So history is like sudden onset chest pain is steroid type the back pain. You had to always suspect aortic dissection. What you can do is you can measure the blood pressure in both hands. Sometimes it can be normal, and there's a pulse difference, and there's a check the femoral pulse also. There can be pretty good radial pulse femoral pulse may be reduced. So if you actually this patient was given enoxaparin, and later the patient has there's no improvement, and they have done the chest X-ray, and they have done a suspected aortic dissection, and the patient underwent CT aortogram, and then patient was transferred to cardiothoracic unit where we replaced the aortic dissection has been repaired. Because very high mortality, if you have actually some patients even can come with inferior ST elevation if the dissection flap obstruct the right coronary ostia. So If you thrombolize the patient, that will be end of the patient. So what you have to do is you should treat the patient accordingly, and you should not harm the patient. So there can be chest X-ray, there's a cardiomegaly, but even chest X-ray can be normal. So there can be true lumen and false lumen. Right. So this patient is a 70 years old male coming, right-sided persisting pain, no exertion angina, no family history, no risk factors except hypertension. ECG is normal. So actually these two patients actually came to me. So this is the only history. ECG is completely normal. So patient having right-sided persisting chest pain. So what do you think? Anything you want to do? Any investigation other than, okay, we'll do echo. Echo is also normal. Any other investigation you want to do in this patient? History is asked, but history is there. I mean, there are no association with like gastritis, no history, no not pruritic type, not increase with movements or anything, but it's a persistent time. There's a localized pain is also there, but there's no local tenderness is there. There's localized pain. Any idea? Or any way you want to do it? Yeah, just chest X-ray. Actually, it's yes. First stress before stress, I would do a chest X-ray because right side chest pain is when the patient come, you can feel this. There's something is not like in cardiac origin. So this is an uncardiac chest pain. So in this patient, actually have a sclerotic lesion in the X-ray and data found to have prosthetic CA. This is actual patient. So about 5 minutes history, you can diagnose it. Not you can diagnose, but you can obviously do the necessary investigation. But if you do like CT, CA, concomitant angiography, unnecessary investigation will actually delay the diagnosis. But if you do a chest X-ray, you can even miss. But better to carefully you can diagnose the patient. And this patient actually is also patient with private practice, 60 years old patient with female central and right side chest pain. She is having external SOB but no angina, and she is emaciated, loss of weight, no loss of appetite. ECG is normal, and with detailed history, she is still find it difficult to swallow also. Some features of gastroesophageal reflux disease is also there, but there's obvious dysphagia is there. You want to tell anything? Well, just because of time constraints, this patient actually have, so what are my diagnosis is non-cardiac chest pain. Yeah, gastritis, gastroesophageal reflux can be there, but you have to always see the patient. Just imagine the patient is emaciated, low, loss of weight. So usually gastritis patient, you don't come with like this patient. You can see this patient is something sinister is going, possibly malignancy. So you have to, obviously there's a dysphagia, so you have to arrange upper GI endoscopy. So of course you can give PPAS and domperidone, things like that, but it does not harm. Yeah, this actually, so patient had a endoscopy and there's a suspicious lesion and it shows a esophageal CA. So these actually real patients who came, because I don't have ECG because ECG is completely normal. So these patients are, yes, you can come with lots of pains, but come with chest pain, but not all chest pains are related to cardiac. And sometimes if a young patient comes, a young boy with tall, you have to suspect pneumothorax, always ask the history and also do auscultation and percussion, and you may find a pneumothorax, and obviously do a chest X-ray. Especially if the young patient comes, do a chest X-ray. You have low threshold, do a chest X-ray. And this pneumomediastinum due to esophageal rupture is very rare, but sometimes they can sudden onset pain while eating, things like that, and they can cough, regurgitation, things like that. So you can do a chest X-ray and you can do pneumomediastinum. So there's a good guideline for this 2021 American College of Cardiology for diagnosis of chest pain. So what they say is, usually previously we tell about this atypical chest pain and typical chest pain, but the atypical is a misnomer and it was widely, so it's like it was used very broadly. So sometimes atypical chest pain, we misguide them. So current recommendation is that cardiac, possible cardiac or non-cardiac. So if I come across a patient and patients he gave history, I usually say obviously cardiac, it's like cardiac. some patients I just like non-cardiac, and there are some instances like there's one patient who came actually like 50 years old female, and she's didn't have any family history or any risk factors. She's can have a continuous chest pain for like 1 day duration, like left side submemory pain. Blood pressure is normal, heart rate is 72. So what I felt it like it's like a non-cardiac chest pain, my initial diagnosis. Then the patient just said this SOB is also there, and so do an echo because she's a sister, retired sister. So the actual patient is like 60 years old, and we did it. There's a ECG is completely normal except the T notion in lead 3, and there are some trivial mild MRDs was there. So then just patient is complaining of so shortness of breath for there. So she says she can't even walk like 100 meters now. So what I think is initial diagnosis non-cardiac. I was thought giving gabapentin or something like neurogenic pain, but then it's just like possible cardiac chest pain, and because we didn't have only one ECG, we have repeat ECG. I just admit the patient, and they have admitted to the CCU, and they also others also have thought it's a cardiac chest pain, and they have undergone angiogram. It was completely normal. So actually, it's a non-cardiac chest pain. So because of this, sometimes we may feel like possible cardiac chest pain also, but ultimately it's a non-cardiac chest pain. So the neurogenic pain. So sometimes first diagnosis may be correct. Your intuition is sometimes come to the play. So if you take the chest pain probability ischemia, it is like a sharp pleuritic pain, positional pain, right-sided pain, tearing, between burning time. Its probability of ischemia is low. Stabbing is also slightly low side. But in the central chest pain, there's a pressure, squeezing, heaviness, you feel like exertional chest pain, retrosternal chest pain, likely of ischemia is high. So this can be used to determine the probability of ischemia. Is it low or high? These things I will not discuss. You can you can see precipitating factors, leading factors, etc. And other things like you have to see the pulmonary embolism, aortic dissection, esophageal rupture. I discuss things also, pericarditis, myocarditis. This also can, especially pneumonia. Lot of pneumonia patients come, they do some pneumonia and very high CRP. There is obvious pneumonia and chest X-ray, CRP like 200s. And the patient also complain of chest pain, usually related to the area of the pneumonia. And they do a troppi, and troppi marginally positive and treat at ACS. So this is more likely due to cardiac. So troppi is not specific to myocardial ischemia, myocardial infarction. So any myocardial injury can cause high troponin I, especially high sensitive troppi. It's like marginal increase can occur even without myocarditis because due to infection itself, inflammation, sepsis can cause myocardial damage due to cytokines and etc., hemodynamic compromise, etc. So they can have slight troponin now. So if you don't have to do even troppi here because it may have misguided the treatment. Obviously, patient have myocarditis, they will have very high troppi. So if you come to the patient with chest pain, you take the context of what is the presentation of why the patient has come to the hospital, ask the detailed history and examination. The ECG shown definite STEMI, you have to follow the STEMI guideline and ACS guidelines. And if you are non-STEMI, you have to follow non-STEMI guideline. And if the patient is arrhythmia, like SVT or atrial fibrillation, you have to treat accordingly. And non-diagnostic or normal ECG, you have to always repeat the ECG and see. And sometimes the normal ECG can occur with the LCX lesion or posterior infarction, like V7 to V9 lesion. You have to do a V1 to V2 ST dips are slight here. You have to do a V7 to V9. Because that is one thing I suspected in that lady who had almost normal ECG, but he had mild MR because some LCX lesion also can give rise to mitral irritation due to papillary muscle dysfunction. Okay, so this patient is a 45-year-old male coming increased chest pain while walking, and patient pain is central type pain with jaw pain. It relieves with rest. Previously, was about to walk around 1 kilometer without any chest pain, but last 2 weeks he can't even walk 100 meters. Smoked 10 per day for 15 years. Father had MI 15 years and died due to MI Examination normal and initial tropi comes as negative. 2D echo, it's no regional motion abnormality, so EF is normal. Anything you want to tell? This is that non-cardiac chest pain, or possible cardiac chest pain. What do you think? Okay, there's one saying stable angina. Okay, so it's cardiac chest pain, but stable angina. Yeah. So you can see this. So the patient have all the risk factors, right? Even if the risk factor patient is complaining of chest pain while walking, so exertional angina is good. I mean, especially if a male patient comes until it will be very highly significant, I would say. And you can see the patient was able to walk around 1 kilometer without pain but last 2 weeks he can't even walk 100 meters. So it was becoming unstable. So history, actually, I just always want to highlight the history. You have to take the history very seriously. So this is a cardiac chest pain, and the patient is previously having stable angina. Yes, around 1 kilometer, maybe chest pain without chest pain, and now 2 weeks he can't walk 100 meters. So this has become an unstable angina. So the unstable angina tropi but initial tropi can be negative, but you may actually have to repeat it at least 3 hours after high sensitivity, because usually we have a most positive one 3 hours, but there are some in Western countries 1 hour is also positive. There are some algorithms you can have 1 hour and that's positive. But if you take 6 hours, of course, it will almost all will have positive. So you take the ECG, and ECG is this is a ECG. So what do you think? You can see the T inversions in V1 to V3, symmetrical T inversions. What are small things like quite significant T inversion, I would say. Any idea? Okay, because of time constraint, I will go. So this is a valence type B ECG. So if you take the ACS, so the history is acute coronary syndrome, likely unstable angina until we do a tropi. If the tropi is positive, it's become a non-STEMI. So valence ECG, valence type B ECG. So we actually did the angiogram. You can see the angio. So there's this is the LCX. It looks normal, and there's a LAD. Sorry. LAD, there's approximately there's a critical lesion like 99% stenosis, right? Because the distal flow is preserved and right coronary artery is normal. So this patient actually unstable angina. This patient. So if the patient is unstable angina, what shall we do? Like we can do exercise. So I will tell the answer. So the unstable angina, you should not do exercise ECG or other stress. This is a high probability of this is a valence type B. So you have to do an invasive angiogram. And what you do is we do a angiogram and see a critical lesion, and you have to revasculate at the same time, because it's not like a 50-60% lesion, it's 99%. If you wait, patient can develop anterior MI. So you insert a guide wire, and put a stent and dilate the stent. And this is a final result. You can actually, these patients actually very benefit from the revascularization because the myocardium is not damaged. Okay, this is a valence type A ECG. There's a preserved R is there. Usually, this type of ECG can even happen with the Q. Only the Q is there. It's more likely a old anterior. But this is a R is preserved, and if you do a echo will be normal. And for your reference, I will do a normal coronary angiogram. This is a normal LCX, normal LAD, diagonal branches, and these are 90 degrees of septal branches. This is the LMCA, short LMCA. This is the right coronary artery. Okay, so this patient coming with ischemic chest pain for 1 hour and ECG ST elevation in V1 to V5. RCS normal, I will just skip. So you can see there's a left side, left anterior descending artery, proximal obtrusion, completely gone. So this is a anterior MI. So you put a wire and put a stent, and that's I'll skip because of time. But this is a acute RC occlusion. So you can see the RC is cut from here. There is no distal flow. So revascularization has to be done. Okay. So this is an acute coronary syndrome patient coming with a PCI center. If the patient, you can transfer within 120 minutes, you can always transfer the patient. But if you think the PCI cannot be done within 120 minutes, you have to thrombolize the patient. I will not discuss about the acute ACS management because of the topic is mainly for the family physicians and general practitioners. Usually ACS, you have to suspect ACS, you have to admit the patient and treat accordingly. And even if can't for the time, you can't go to the details. So this is the other pattern you have to identify. It's a D Winters pattern, like sloping ST depression and high. It's like T waves are like hyperacute T waves. So this is a impending anterior MI. So even than the valence, this is highly significant. You can also see the reciprocal changes in the inferior leads, 2, 3, and AVF. So this is a impending anterior MI. There are some trials they have even thrombolized for that, but should not recommend that. But within few minutes, patient will develop anterior MI. This is a, you can see there's a AVR ST elevation is been there, and also slight ST elevation in the V1 also, and widespread ST depression you can see. More than 6 leads, there's widespread ST depression. This patient coming with 70 years old diabetes, coming with chest pain, class 3 to 4 CCS class, and blood pressure is lower side, and patient is in cardiogenic shock. So this patient is having a severe left main coronary artery disease or severe triple vessel disease, etc. So other thing you have to check, if you see a LMCA pattern ECG, you have to always check whether the patient is pale or not. So this is actually a real patient who came with patient with chest pain and dyspnea, mainly dyspnea for persons several weeks, and the ECG was B. So this is also ST elevation in the AVR plus V1, widespread ST depression, but slightly different than, but you can sometimes even can't differentiate between ischemia and the due to anemia. This patient was HbS 4.9. So sometimes you see a ECG. I have seen they have even given enoxaparin and antiplatelets. So this is a type 2 MI. Even if you trophize positive, it's a type 2 MI due to severe anemia. So if they take the patient had a malign actually for several days. So if you give enoxaparin and antiplatelet, you are doing more harm. So you will not harm the patient. So you should actually, patient should actually, statins of course you can give. We have to replace the red cell, and first of all you do a full blood picture, and obviously patient will need upper GI endoscopy and endotherapy. Patient will definitely have a upper GI ulcer. So this is a, can see is almost looking a normal ECG, but just if you take a course, really you can see like slight hyperacute T waves in anterior leads, and there's slight ST elevation in one AVL, and marginal ST dips in 3 and I would say 3. So this is a evolving anterolateral STEMI. So what do you think about this one? So this is also like similar, but there's like patient. So this patient actually just an incidental pain, incidental finding. So patient can be some, suppose some for leg wound while doing some work, manual work. So this is was diagnosed, and they were very curious also, like the same patient with LVB. So what I'm going to do? So patient does not have a history of any chest pain. They do several ECGs, same pattern, no evolving and they want to tropize. I would not do a tropi. Because this is like a benign early repolarization. You can see a notch in the J point, and if you take the heart rate increases, usually it will become normalized and less prominent. So you can actually do a walk-in ECG. Ask the patient to walk fast for 6 minutes and do a repeat ECG when the heart rate is very high. Usually, if the ischemic origin, it will be like positive. But if the benign early repolarization, it will be less prominent. So this is also showing ST elevation, widespread ST elevations. And the patient's chest pain, patient is coming with like shouting in pain, like this is not the real ECG, but this patient just come. Patient when the outpatient, the patient was shouting like usually in that case I know that it's not a ischemic pain, of course. The patient just looks shout like that. So and with the history of SARS, patient says worse with the lying down position, relieved with bending forward. And patient, when I asked, the patient had a recent history of respiratory tract infection. So pericarditis. Echo actually it was having thin pericardial effusion, maybe it can be normal even. So usually viral, the cause rarely can be TB also, you have to check in that, but usually in the viral origin. Take the history correctly, you may avoid other investigation, but you can obviously have to do echo. Obviously. So you can see the ST elevation and reciprocal ST dips in AVR, and there's PR depression is also there. So widespread ST elevations, and there's even if you do repeat ECG, it will be same. There's no progression. So there are some few questions asked. So they have someone like what how to find hypertrophic cardiomyopathy. Also, this if you take a ECG like this. So I have seen these type of ECG also treat as a non-STEMI. So take the context. So sometimes the patient is not coming with chest pain. In that case, you have to suspect like this deep that T inversion, symmetrical T inversion in lateral leads. You have to always suspect hypertrophic cardiomyopathy. Sometimes severe LVH due to uncontrolled hypertension also can give rise. Also definitely ask about the family history. Usually patient may be asymptomatic, patient may have symptoms. So what are symptoms in hypertrophic cardiomyopathy? They can become asymptomatic, they can have family history. Sometimes they can have exertional SOB, due to dynamic LVOT obstruction, and sometimes the patient have angina, sometimes patient have heart failure, sometimes patient can have atrial fibrillation or ventricular tachycardia, ventriculectomy, which also makes sudden cardiac death also. Other thing is there are dagger-like Q waves can be also there. So inferior and lateral leads. Those are things in hypertrophic cardiomyopathy. So if you take the two ECGs, so this is a use of AI in ECG diagnosis. There are some applications are there, and most are not free actually. You can do like 5 ECGs for free. So there are PM cardio, this called AI is there. So it obviously looks almost, you can see like a normal, you may see, but this is a slightly ST dips in the inferior leads are there. So this is a slightly, I will take a significant. So you have to suspect any anterior MI is evolving or not, but sometimes even you can miss it. This ECG looks normal. It looks like a benign repolarization to me. Always you have to take the history, but suppose the history is not given and you just give the ECG. So most patients are coming in chest pain, so very suspect, but if you take the detailed history, you might find it from the history itself. So this is the AI diagnosis. So this is a OMI's occlusion myocardial infarction with high confidence interval, and this is saying not OMI with high confidence. So there are ways they can measure with machine learning. Okay, so now we'll go for the how to approach the cardiac. So we just come with the patient with having chest pain and which are not due to cardiac diseases, and now we are going to address mainly the cardiac chest pain. And mainly so we have discussed about about the ACS, and now we are mainly going for the chronic coronary syndrome or stable angina or heart failure due to ischemia, because those are the patients you will mainly get in the outpatient. for general practice because other patient will be present in the emergency department. So there's a 2025-24 EECC guideline for CCS. So the ACS is acute coronary syndrome, CCS is chronic coronary syndrome, other than the acute coronary syndrome. So they can have a variety of presentations. They can have asymptomatic completely, but abnormal coronary anatomical tests like CTCA or XRCG they underwent due to this insurance thing or just for just the curiosity that then found to have coronary artery disease. Then the patient have angina but non-obstructive coronary. Usual obstructive coronary disease is defined as more than 50%, non-obstructive less than 50%. So if coronary disease is around like 30-40%, but the patient has chest pain. So this have angina of non-obstructive coronary, so ischemia in non-obstructive coronary disease. Other thing is patient have stress in exertional angina or equivalent like exertional dyspnea with obstructive coronary disease. Other patients can have a post-PCI or post-CABG. Those are also CCS because they will need treatment lifelong. And sometimes the patient will due to LV dysfunction, due to heart failure, due to ischemic origin. These are the presentation of CCS. So if you take the step-by-step approach, you have to initially evaluate for chest pain, then further evaluate and confirm the diagnosis and treatment. So I will go by each by one. So if you take the history examination, ECG and TROP-I, biomarkers mainly. If you suspect heart failure, you can have a pro-BNP, anti-pro-BNP also, and lung function test and chest X-ray. And non-cardiac chest pain, you have to treat accordingly. And if you are unstable angina or ACS, you have to treat accordingly to that method. So if nothing is there, you have to go for the second step. And some characteristics of cardiac chest pain is like I discussed before also. So I'll skip these slides. And dyspnea also is like there. You can later, I'll share the presentation so you can later go through the slides later. So if you evaluate the further, you can, when they assess the likelihood of coronary artery disease, now we have this risk factor weighted clinical likelihood model. So you can do a clinical data to adjust the risk factors. So if you to assess the history and examination, you can do a XRCG or echocardiogram also. But if the risk is very low, less than 5%, you don't need any other testing. So you can reduce the unnecessary investigation if the risk is very low. And if you have severe comorbidities or low quality of life, like if you take a cancer patient having less than 6 months of life expectancy, you don't have to investigate further. So you have to first there are three processes. First, you have to assess symptoms. So symptoms, you have asked about the type, aggravation, and relieving factors. You can give 1 point to each. So if the patient have all three, it will be 3. And dyspnea, you can maximum marks is 2. So dyspnea, chest pain, you can either 0 to 3. Dyspnea, you can have dyspnea, they are not 2. Then number of risk factors. There are 5 risk factors: family history, smoking, dyslipidemia, hypertension, diabetes. So if the 5 are there, 5. So if you take the age of, suppose we'll take age of 42 years. So this is a category. And suppose we'll take the male patient, 40 years male, you have go to this category. So if the patient have symptom score 1, only the location is there, so you can 40, 1 is 0 to 1 is 2. Suppose the same patient have a symptom score 5, 40 to 49 years, symptom score 5 means 27. So you can see that if this patient, the symptom score is 4, you don't have to investigate further, but there are other things you have to, I'll come later discuss. 27 is high risk. So maximum risk is 45, what you can get, lowest is 0. Then from symptom score, you have to, so these are the, again, number of risk factors. These are the main 5 risk factors. So again, the symptom score, you have to go to the next line. Next thing, you have to adjust the clinical likelihood based on abnormal clinical findings of coronary artery calcium score. calcium score is actually better because you can actually suppose this patient is having 60 to 65 years patient having 2 risk factors, symptom score 14. So initial risk factor which is clinical likelihood of coronary disease is 14. But if you do a coronary calcium score, if it is 0, this calcium score based risk is less than 5. Say it's around 3. So each patient does not need any further testing. 14 will be needed for them, but if you do a calcium score and take it out, but patient does not need symptom and treatment. Suppose the same patient have high calcium score of life. Suppose we'll take 100, something like that. 100 means this. Yeah, so it's like coming to 20%. So patient will need further evaluation like that. So, but if you if you don't have the calcium score readily available, what you can do with clinical findings like resting ECG changes, exercise ECG changes, LV dysfunction, arrhythmias, peripheral heart disease, or pre-existing chest X-ray CT showing a coronary calcification. These are not graded, so not like this. So there can be calcification which is not being graded. So, and the clinical decision comes here, and you can, but you can't actually give a number here. So if you want 45, what is the LV dysfunction can add? So it's difficult to tell. But if you have a calcium score, it can definitely give a correct number of likelihood. Like that, if the very low likelihood, you don't need any testing. Provide 15, you can either do anatomical testing like CT coronary angiogram, or you can do a just clinical likelihood from echo and CT, previous CTs and listing ECG changes, etc. And a moderate 15 to 50% is there. CTC or functional imaging can be there. The very high risk of there, you have to do a functional imaging. And it's so extremely high risk, like more than 85%, you have to undergo an invasive angiogram. Risk factor is it is available in the this ESC application. You can go through it, and even the PDF is there. What you can do is you can take a printout and take it. So this patient coming with chest pain. There are other factors like preventive risk score like score 2. So score 2 is not for European countries, but there are WHO, LDR Sri Lankan also, but it's not that good as the score 2. So you can use for the private prevention guidelines also. But these are for patient coming with chest pain. You are suspecting chronic coronary syndrome. How do you investigate? That is the approach. So there are the functional testing. What we have is stress echo is a wide level vitamin stress echo is the one thing we can do, but for the good quality we have to have the contrast agent. Oh, but we don't have that contrast here. Other thing is we have to work stress CMR, cardiac MRI, or PET or SPECT. SPECT of course CMR we have, but the PET is actually superior to SPECT. But sensitivity and specificity low. I will not go to the details. You can go through leisurely, but so if you take a CT angiogram is conventional invasive angiogram is a transradial or transfemoral arterial approach. It's always better. But CTCA is a non-invasive and slightly reduced radiation exposure. Okay. So there are other things. So problem is that we have CTCA, but we don't have the CT-FFR. FFR is actually this. Sometimes the patient can have 60% lesion, 70% lesion, etc. But that may not be the cause for the ischemia or angina. Suppose some lesions can be 60% and can be significant, but some lesions can be like 70%. Still, it does not cause a pressure drop. So usually, come easier terms, it will be like a pressure drop. So it is like a 0.8%, less than 0.8, it's a significant. But if the drop is FFR is more than 80%, 0.8, it is not significant. So the CT-FFR, you have to, there's a called heart flow, we have to send it to the this USA. I think it's very costly. So usually FFR CT is not being done due to cost and there's no, you don't have the software.
නෑ මම හැදුවේ මේ 120යි. කිර්
Yeah,
ටික දානකොට ඒක වැඩි වෙනවා 130යි 160.
okay. So you have stress echo coronary CT angina. If you take a CT FFR, sensitivity and specificity will increase, obviously. So you have around sensitivity around 90% and specificity around 0.8. The stress echo we have is also good, but this is with the available contrast. But if the patient has good poor quality windows, we may miss it. XRC usually around 60 to 70% sensitivity and specificity, depending on 79. But the patient should not have a LBB pattern ECG. Patient should not be digoxing. There is no. If the patient have a resting ECG ST segment patients, it's very difficult to diagnose. But if the patient is having a good exercise, or what they tell is if the patient has to exercise like more than 5 minutes, so it's a good thing. You can see any patient's prognosis. You can determine the patient's quality of life, functional capacity, and if they have good blood pressure response, etc. So I will not go into details. So there are CT angiogram also. There are now there are some programs which can give like a virtual histology and give likes to what is actually there. So like a virtual histology, you can tell the high lipid plaque is there, fibrofatty fibers which are more stable, and what are the unstable plaques. So these are the high risk plaque is there. Always have to do aggressive therapy. So the benefit of CT angiogram is actually it's not the intervention. If you diagnose CT, if you do a CT coronary angiogram, and if you find that about 40% lesion, so the patient and the clinician will aggressively manage the patient risk factors. So that risk factor management from the guideline directed medical therapy is the one giving the prognostic benefit, mortality benefit in the CTCA, not the interventions. So then you diagnose and confirm the diagnosis. You have to do invasive angiogram, functional imaging, etc. Like very high risk, 80% likelihood, invasive angio, 15 to 85, functional imaging, or 15 to 50, you can do a CTC. Right. So initially, in those days, we only can go discuss about this coronary, epicardial coronary. But nowadays, there's a thing we can only see about 5% from 5 to 10% coronary angiograms, but more than 90% it's microvascular circulation. We can't actually see. So if you get a treatment, there are treatment to reduce the symptoms, treatment to improve the prognosis. To reduce the symptoms, there are anti-angina drugs are there. So this is a good article to read from 2019. Diamond approach to certain angina, and this is they have like the patient of bradycardia. What is the preferred one? What is the non-preferred one, etc. The patient is an AF. What are the preferred anti-angina drug, etc. You can go through it leisurely. So now ACS guideline, CCS guideline also give rise a similar pattern of diagram. This approach. So the patient mainly we have now you don't have first line or second line is anti-angina. So you have what are we have beta blockers, calcium channel blockers, dihydropyridine and unhydropyridine calcium blocker, trimethoprim, ranitidine, ivermectin. But ivermectin is now low graded. So ivermectin not usually used unless the patient has ejection fraction less than 40. If it is more than 40, it should not be ivermectin for angina. And nitrates and nicotinamide also slightly downgraded, but nitrates obviously has a good place. So according to the patient have COPD, the patient you have to like be cautious. But patient have obstructive coronary artery, microvascular dysfunction, heart hypertension, AF, heart failure, digital function, beta blockers are preferred, etc. But it is not preferred in sick sinus, no, contraindicated sick sinus syndrome, not preferred in COPD. But COPD patients, you can actually give beta blockers, cardiac specific beta blocker, bisoprolol. There's no problem. So you can continue with beta blockers with inhalers. So if the patient is having obstructive coronary artery disease, vasospastic angina, AF, will try some verapamil preferred, but if the heart will reduce verapamil is not preferred. So in that patient, you have to go to beta blockers, etc. You have to tailor the treatment according to the patient profile. So it's a patient-centered medicine. So if you take mechanisms, can be epicardial dysfunction, epicardial coronary artery disease, or microvascular. Epicardial can be structural or functional. Functional is like vasospasm. Sometimes a patient female patient having chest pain at the night can be due to reflux disease, can be due to asthma, but it can be also due to vasospasm. So if you diagnose it, it's very difficult. You have to do the ECG at that time. But one thing you can do is you can do a Holter monitoring or ambulatory ECG monitoring. But if the patient have daily symptoms, if the patient is getting chest pain at one name and there's at one name there's ST elevations there, you can actually correlate with that. Or in the otherwise you have to do STI calling and induce it in the with the cardiac coronary catheterization. Structural can be atherosclerosis, mainly hematoma, and there can be myocardial viscosity like muscle bitch and coronary artery aneurysms. These are very rare. Mainly seeing atherosclerosis is the main thing, and rarely myocardial BG. And structural disease like microvascular of functional or structural, there can be left ventricular end-diastolic pressure overload due to aortic stenosis, hypertension, and perivascular fibrosis, capillary artery because capillaries are less, and arterial remodeling, and functional due to impaired vasodilatation or increased vasoconstriction. So this is the one called ANOCA and MINOCA. So if you take only the out of 100%, obstructive coronary artery disease is only 50 to 70 in males and 30 to 50% in females. So females, it's more than 50%. It is non-obstructive coronary artery disease. But they have angina. They can have ischemia as well. If you take the ischemia is only 25% ischemia, but without ischemia, they can have angina. To demonstrate ischemia, you have to do a stress echo, stress CMR, SPECT, PET, etc. But angina, of course, patient can tell angina is there. So there are various things like coronary flow reserves and things like that, which will be discussed here. There are various endotypes, endotype dysfunction, microvascular angina, vasospastic. Both types are there, like things which are a bit complicated, and we don't do these tests in Sri Lanka also. So if you take the microvascular angina, you do an angiogram and or CT coronary angina, there's non-obstruction is there. First, you have to consider statins and ACE inhibitors, and the patient's abdominal vasodilatation is suspected. You can start beta blockers, calcium channel blockers, and ranitidine. And if the abdominal vasoconstriction is suspected, epicardial, calcium channel blockers and nitrates are the preferred drugs. In microvascular, you can do mainly calcium channel blockers and nitrates. So if you don't know the diagnosis, but what you can do is always start statin and ACE inhibitors, then start beta blockers, calcium channel blockers, and nitrates, and see. The trial and error. Actually, some patients respond to some patients respond to only to some medication. Other thing is you can always give ranitidine, especially to a diabetic patient. So endothelial dysfunction is suspected. You have to go ACE inhibitors, microvascular angina. First line is beta blockers, vasospastic, calcium channel blockers or nitrates, and overlapping. You can need a combination of treatment. And medical therapy for reduction of other things like smoking cessation, Mediterranean diet, weight loss, physical activity also reduce the cardiac mortality. So improve the prognosis, there are 4 categories: antithrombotic, lipid lowering, anti-obesity, and anti-inflammatory drugs. So antithrombotic is you can have aspirin, clopidogrel, prasugrel, ticagrelor, but aspirin, prasugrel, and ticagrelor are given for PCI patient, but for medical managed patient, only aspirin and clopidogrel. And also rivaroxaban low dose you can combine. So those days default approach is for 12 months. Now the default approach is 6 months dual antiplatelet. Then aspirin or clopidogrel. Now some trials favor clopidogrel also, but post CABG it's definitely mainly aspirin. But if the patient is a high bleeding risk, you can stop dual antiplatelet after even 1 to 3 months. Then single antiplatelet. And if the patient has high ischemic risk, you can give dual antiplatelet for 6 months or even longer, 12 months, or even longer, like 36 months, 3 years, etc. But some patients may be lifelong. Suppose the patient is having severe triple vessel disease, uncontrolled diabetes, and the patient was having angiogram, but the patient was not suitable for PCI, and patient is awaiting CABG, but the CABG list may be like 4 or 5 years. Patient should be on dual ventilator. The thing is, you can always combine the role of rivaroxaban 2.5 BD, 2 and dual ventilated, or with the aspirin or clopidogrel with the rivaroxaban. So if you take atherosclerosis, it comes very, if you take the family has a hyperlipidemia, sometimes even at the age of 2 years, they can have developing atherosclerosis. I have seen a 12-year-old boy coming in the left main coronary artery obstruction, like 70% or something like that. The patient had a actual syncope. So then the patient, both mother and father had a hyperlipidemia, and they are actually blood relatives. So the patient's child has got the genes from both mother and father. So what we say is reduce longer the better, lower the better, and earlier the better. So if you take a hyperlipidemia patient, you should start low as possible and long as possible to reduce the cholesterol load, LDL load, and early as possible. Especially if the patient is a young patient, they have more benefit than older patients. Suppose the patient is 80 years old, LDL is 180. You don't have to worry much. You have to worry much, but you can start even toasted in 20 and like that. But if you take a 30 years old patient, male patient coming with LDL 180, you have to start a very high intensity study because the patient have to live longer. So this is the average reduction with statins, etc. Statin modernity 90 to 50, and etc. You can reduce it more. So I have summarized every available lipid lowering treatment here. This is a JAMA cardiology article from 21. So first we go statin and ezetimibe. These are for family hyperlipidemias. Then what other drugs we have is we have ezetimibe and first statins and ezetimibe. Then we have bempedoic acid, which is not available. It's available in India, but not licensed in Sri Lanka. And some backpackers bring it. Less side effects than statins, especially statin muscle symptoms are less. And then the PCSK9 inhibitors are there, but it's very expensive. Then there are other like evenocumab, pramipramide, inclisiran, things like that, which is also there. So can take daily medicine, monthly PCSK9 inhibitors. Like there are inclisiran, you can give like 6 monthly. There are coming vaccination and gene editing may come in the future. So if you take the Indian European guideline, here in European guidelines mainly have this high risk patient LDL reduction is very high risk, 55. But if the patient have another ischemic heart disease, while it is like suppose if less than 55, but the patient is having stroke or MI or peripheral heart disease, with that you have low is to 40 or low. Other things, low risk patients. High risk patients, very high risk 55, high risk patient you have low LDL for 70, and low risk patient you have LDL for 100, and 116 is the lowest category. So, but if they are Indian guidelines, they have very strict targets, so they are coming with low risk with 100. Is for European, this is 116. Moderate risk, they have LDL is optional 70. High risk, they have optional of 70, same as European. Very high risk, it's 50. European guideline, it's 55. Extreme risk patients, like they have European guidelines less than 40, but Indian guidelines less than 50, and optional to increase less than 30. And extreme category, there's other category, they ask to reduce to less than even 30 in terms of the of LDL. So this is they mentioned they have recurrent cardiovascular events despite around 30. What they have suggested, the patient is you can start icosapent triglyceride, colchicine, with high sensitivity CRP is more than 2 dual antiplatelet therapy, 2 low dose rivaroxaban, and still 2 inhibitors or GLP-1 receptor agonist. And recurrent events you can even go over to 10 to 15. So their guidelines are very strict. Indian Lipid Association guidelines are strict, more strict than European guidelines. So other thing I have to mention, shows 10. I will quickly go through a few slides. So I have to, I think it's very important to highlight this one. Also, physical fitness is a predictive of cardiovascular disease more than any other disease. So if you know diabetes, more if you take the diabetes, you know it has a more bad prognosis than most of the cancers, but still its hazard ratio is 1.34. So obesity, because there's a something high obesity. Sometimes the patient is obese. There's obesity paradox called if the patient very low BMI, even they can have a high mortality. So that's the around one. But diabetes is 1.34, smoking 1.4, CKD is 1.49. But if you get a sedentary lifestyle, the least sedentary patient will have a hazard ratio of 4. It is more than diabetic or smoking or CKD. So it's a very high risk. Most risk is the sedentary lifestyle. So if you take this fit, healthy, highly fit and extremely fit patients, if you take, you can't compare the numbers because obviously extremely fit patients number is less. If you take the percentage, highly fit patient 1.8% of death in 30-40 years, but low fit patient now, least fit have 10.8, like 5 times 5. So if you say like 6 to 69, if it is like 0.28% highly fit, but they have 1% in the least fit. So it's very important. And if you take the metabolic meds we have to do exercise, usually the 30 to 49 meds, average med is like 10.8. But if you take 70 years, like the average 8 point, if you have 8.81 meds, the relative risk is more than 50, reduction is more than 50%. So if you take the weight loss and burn fat, you have to obviously reduce the intake and increase the expenditure. There are non-exercise activities, exercise activities, and increase the metabolic rate and foods causing increase. No, I will not discuss, go to details because of time constraints. So you have to always focus aerobics, resistance, main two categories, and also flexibility and balance because they will reduce the falls. So if you sedentary lifestyle, usually measured as less than 5,000 steps. So if it is more than 7,500, more the steps count, it is actually better. So life diet is low carb, adequate protein, and more fish, fruits and vegetables. So we are doing the anti-obesity drugs. Obesity drugs, what we have is liraglutide, we have, and naltrexone and glucagon combination is not there, but bupropion is there, and orlistat is there, but they have a lot of side effects. Yes, side effects. But the preferred drugs in the other countries is semaglutide and tirzepatide. If you take the weight loss from those categories, if you lifestyle intervention alone, around 3 to 10% regular activity. Weight loss may be not that good, but other benefits are there. Just so don't start by the reduced weight loss. But obviously, if you can combine diet and physical activity, they can have more. But if you get treatment, like orlistat 4%, if you take the semaglutide, it's like 12.5, tirzepatide, dual GIP and GLP-1 agonists, you have around 18%. And bariatric surgeries have around 25 to 30% like. So other thing is you have to target the residual inflammation there. So some patients, even LDL reduction is there, they can have persistent inflammation is there. So inflammatory high conditions are like these. So low dose colchicine you can give for these high sensitive CRPs more than 2. So this is a simplified version. So if you say high sensitivity are more than 2, you can give anti-inflammatory drugs on top of anti-anginal drugs I discussed previously. And lipoprotein A also very important. They increase the atherosclerosis, inflammation, and thrombosis because interfere with the fibrinolysis promoting coagulation. So it's genetically determined. More than 90% genetically determined. If it is less than some tests, some guides says less than 20 is low risk. But if it is more than 50%, it has a very high risk. So the genetically determined thing, you have to do it only once in a lifetime, but cost is slightly high, like 11,000, 12,000. But you don't have, but if you have a family, better to do it. But even if you don't do it, if they have a strong family history, you have to treat it, statins and other drugs. And other arm is for chronic coronary syndrome and revascularization, but you have see the cardiac mortality is less with revascularization, and spontaneous MI is less because procedural MI is high. You do MCABG, you can have procedural MI, but spontaneous MI is low with revascularization. But all-cause death is similar, so there's no all-cause mortality benefit. So if you take the EF less than more than 35, you can have CABG or PCI, but the patient have complex anatomy, preferably CABG. But the EF is less than 35, the surgical risk is high, PCI is indicated, but if the surgical risk is not very high, CABG is the best option if the EF is low. The patient has a multivessel disease like multivessel disease, anatomy, you have to check the anatomy. This is also called syntax score. I will not go details. The syntax score is very high. You have to do a CABG is best one. And if the surgery risk is high, obviously PCI. Surgery risk is low, and multi-vessel coronary disease, CABG is the preferred one. And the diabetic subpopulation, you can see always diabetic patients are better from CABG. So in the patient have diabetic, usually CABG is the preferred treatment over PCI. So if the PCS patient on optimal guideline directed medical therapy and even patient still have symptoms, you may have to think about the invasive management. If the patient is having LV dysfunction, worsening LV function, ventricular arrhythmias, you have to consider invasive management. Other thing is mainly important is what is no point even what you give the treatment, you have to check whether the patient is adhered to the treatment. And the patient, we have discussed with the patient and patient centered and decision making the patient. Take the patient's concerns in the decision making, so they will likely to adhere to the treatment. And also you have to target things like polypill to reduce the pill burden. Okay, so this patient, I will few slides are there. It's 45 patient is anterior MI 1 week back and a PCI to LAD and still having SOB and angina, but no angina, blood pressure is higher side, EF35 and apical hypokinesia. So you can see this is a old anterior MI and patient is in heart failure reduced ejection fraction. So HFrEF management, usually we have to start actually these 4 drugs, ACE inhibitors or ARNI, beta blockers, MRA, DAPA, empagliflozin, and EF is QRS is wide. There's a place for cardiac desynchronization therapy. And EF is low. There's a place for ICD also to prevent the sudden cardiac death. But we have to obviously wait for this patient. Not obviously you can't put ICD because you have to wait at least 6 weeks to check whether the EF improves. So this is a complete slide of the heart HFrEF management. So baseline 4 drugs we have to give. But if we do all this, you can do diuretics. There's a LBB or QRS wide. This patient's QRS is not wide, so this patient does not need CRT. Okay, so this is important. So if you seek only RAS inhibitors, you can see, but if you combine the treatment, the hospitalization of heart failure is reduced. So always have to have all the drugs. How to optimize, like within like few weeks, because if you take the mortality of heart failure, which is very high within the first month, so you have to like first 2 days within discharge, you have to try to do half doses, optimal doses in all 4 drugs if possible. Within 2 weeks discharge, you may try to do full optimal doses. And if the heart failure mid-range is for like 40 to 50%, there are mainly the treatment is SGL2 inhibitors and class 2B recommendation is inhibitor, ARNI and ARB and MRA and beta blockers. And HFpEF management, mainly what we have is SGL2 inhibitors. But if the patient is having congestion, you can do diuretic. If the patient is having If less than 55 and female patients, you can add a MRI, spinal electron or epineural. And if the woman or patient with LVF of 55 to 60, you can consider ANI also. It's not intolerant to ACE inhibitor ANI, you can start a ARV. Okay, these are the things, but when we go to the cases we discussed before. Meenal, if you have any questions, please ask. Okay, LVB patient, of course, we discussed, so we don't have to go into again. So in this patient, what do you think? So patient 39 years old, smoking 5 cigarettes per day. Father had MI, strong family history. Mother diabetes, sister CABG. So you can see the very strong family history there. This patient have a very clinical likelihood of to take. Is no time to put in the chart, but will have a high risk of high likelihood of coronary disease. Even resting is normal. Fasting 106, LDL 110. How are you going to investigate and manage this patient? Anything you want to suggest? So this patient is likely cardiac chest pain. So this patient may be, so if you take some chest pain, patient may have chest non-exertion angina, but only chest pain at rest, can be a possible cardiac chest pain. If the patient is related to angina, it is more likely cardiac chest pain. But if this is one has a CT angiogram. Yeah, obviously we have to put it to the chart and see what is the risk. So this patient is more likely to have a coronary disease, high likelihood of coronary disease. So in this patient, preferably functional imaging is better, like a stress CGO, spectro imaging. Otherwise, even conventional angiogram will be a better option. Depending on the chest pain, depending on the system, but you can obviously do what we have. We don't have other facilities, so you can do XRCG. The XRCG is negative. You can do a CT angiogram. If XRCG is positive, there's a place for angiogram, invasive angiogram. So other thing is CTFF-CT. We have only the functional imaging. So there are what I have seen is practical. The guideline is not there. There are some patients with family history and insulin resistance. They have a thing called microvascular dysfunction, which is we don't have this calling and things, adenosine things. We do it in routinely. But what you can do is, if you do angiogram, you can do a slow flow. The velocity of the angiogram, so previously angiogram goes very fast, but in these patients, angiogram goes very slow. This goes slow flow due to microvascular dysfunction. It can be only found in the coronary invasive angiogram, or you have to do a CT-FFR, because CT-FFR we don't have. To do a CT coronary angiogram, we can even it can be normal, so it can be misguided. So that is the danger here. And the fasting blood sugar 106. So what are you going to do? Are you happy with that, or are you not happy with that? And LDL 110. Are you happy with that? LDL is not very high, I will suppose, but are you happy? So there's a called diabetes, pre-diabetes, and normal. So if the fasting blood sugar is less than 100 is normal. If it is more than 200, 126 is diabetes. But in between, it's an impaired fasting blood sugar or pre-diabetes. So always have to do other tests like HbA1c, glucose tolerance. You don't do glucose tolerance routinely, but you can do HbA1c. Sometimes I have seen is fasting blood sugar around that, but HbA1c is high. So because the development of is the onset of diabetes, but before onset of diabetes, there are definite macrovascular complications occur because of hyperinsulinemia. Because of insulin resistance is occur beforehand. Insulin resistance occur even before developing of diabetes. And sometimes the patients even have low postprandial blood sugar. Because of high insulin resistance, their postprandial blood sugar can be even less than normal. So don't be misguided by that. So even microvascular company develop before onset of the even the cutoff is 100, but some says fasting blood sugar around 80 is very better, but less than more than 100, so you have to be very cautious. Other thing is patient triglyceride is also higher side, which showing the patient is having caloric excess. Patient is more eating more and possibly patient having diabetes or metabolic syndrome. And HDL is also low side, less than 40 is showing the metabolic syndrome. And if you take the HbA1c patient 7.1, lipoprotein is 66. So you see even LDL is around 110, ILP is 66, very high risk. So you have to give a high intensity study of this patient irrespective of coronary angiogram for primary prevention. But if you don't have lipoprotein, that is the important of cost-effective ways to ask about the detailed family history. The family history is very, there are some studies showing artificial intelligence, and also they have shown even family history is also like same as some algorithms. So always ask about the family history, and if the patient can afford, do a lipoprotein. So this patient actually need lifestyle modification, diet, exercise, things, etc. And for HbA1 for patient is diabetic, of course the patient will have anti-diabetic medication, metformin, pioglitazone, etc. Patient should be on high intensity statins. You have to investigate and treatment according to if the patient have coronary heart disease, even no ischemia, patient will benefit from aspirin. So what they say is, so obstructive coronary disease, there usually aspirin is recommended. But even is less than, I would consider aspirin because most of the coronary STEMIs occur with the less than 50% stenosis. And this patient, 48, was diabetic for 6 years. Fasting blood sugar very high, but obviously high blood sugar is not controlled, and patient exertional dyspnea, high BMI. Patient is not only given glycoside and losartan. So these I have seen several things. You have to, also the patient is given low dose of atorvastatin, so like 10 milligrams. So if your patient is a diabetic for more than 40 years, you definitely on a statins, high intensity statin, atorvastatin 40 to 80 or losartan 20 to 40, like half of the atorvastatin. But if the patient is risk of developing diabetes, not this patient, but previous patient, suppose even HbA1c is pre-diabetic range, so atorvastatin is better, and the patient is having develop a CKD risk is low with atorvastatin. So usually atorvastatin is preferred, and you should always try to give something like GLP-1 receptor agonist, but may not be practical in our setup due to cost, and SGLT2 inhibitors and things like metformin. And you have to obviously treat with hypertension. Initially, most of the patients are ARB, but the most of the trials are favoring ACE inhibitors. So always try with the ACE inhibitors. Ramipril is preferred ACE inhibitor, but if the patient can't afford NRP. But when the patient will have very high dose of NRP, like 10, 20, 10 BD, etc., they will develop some dry cough, but not very low, not for very low doses, like 2.5 BD, 5 BD you should tolerate, but very high dose of ACE, they usually develop dry cough. So obviously blood sugar is not correct. HbA1c is more than 10. Usually the patient might need insulin as well, but when the glucose toxicity is reduced, patient may even benefit from oral hypoglycemics alone. Obviously, patient we have to go strict diet and exercise, reduce carbs, etc. Even LDL is 110. Every diabetic patient more than 100 LDL should be given, but if you take this patient actually need LDL reduction of less than 55, I would say. Okay, any other things? Okay, so we have few questions. So do you recommend any objective assessment as physical fitness like questionnaires at GP levels? Yeah, it's very difficult. Like you can always ask about the physical fitness, better to do, because you can ask about whether the patient, if the patient can climb like 2 flights of stairs, usually MET is more than 4. Usually have mild fitness level is there, but for a comprehensive assessment, better to do a exercise ECG, because exercise is like it's a standardized method. The boost protocol is there. You can have some guideline. because otherwise we may ask what is the patient exercise tolerance. The patient may even lie to us, but you can do a baseline ECG and echo, and also exercise ECG. What is she's available here. And CT. So in the question 1, LBB does not need anti-anginal drugs or antiplatelet other than antihypertensives. In this patient, actually I don't do anything. But I will definitely do a fasting blood sugar lipid profile. If the fasting blood sugar, definitely treat for diabetics. It's like because you have to treat it for primary prevention. But if the lipid is high, may have to start antihypertensive, but definitely not aspirin. But if the some patients with LBB have a low EF. So if the patient's ejection fraction is low, then there's a place for heart failure treatment, obviously. You can even give beta blockers, things like that, without any problem. This patient likely to have more like the history present, more likely to have degenerative changes. But if the patient with other things like cardiomyopathies and things like, you have to initiate. Usually, if the female patient with LBB, usually they are for even males, they are non-ischemic. But actually, when we do the angiograms, we actually first we like to do a normal angios because you don't have to delay the list. So what we do is we select the LBBs and do the ECG. So because more than 95%, we know the LBB ECGs are going to be normal. So that is the usual experience we have. In elderly and calcium alone, yeah, the most elderly patients, there can be vessels can be calcified, but usually calcification alone does not happen. Usually, on top of atherosclerosis, they can have calcified vessels. Because of this calcified vessels, usually they are actually usually stable. There are some specific calcification, specific calcification, we can increase the risk of coronary disease, MI. But usually, elderly patients, usually they have, and CKD patients usually have calcified vessels. So it is per se a risk factor. And for the things I got from this Q&A Google form, I discussed about the ECG patterns, and there are some questions like what is the preferred anesthesia after recent MI. But if the surgery is not urgent, you may have to delay the surgery at least like 6 weeks to 3 months, like depending on the risk. But preferred is the general anesthesia as a preferred anesthesia, and you have to reduce the fluctuations of blood pressure, pulse rate, and reduce the pain, and liberally give the morphines. And there's a question called like morphine dose. Usually it's like 1 milligram per kg. It's like 60 kilograms. You can give 66 milligrams. You can give IV, but if you are worried, you can give a subcut to IMU or even. But even usually 3 to 5 IV is enough. But if you go to subcut, you may go into 5, 10, etc. And the adults and teen versions in V1 to 3 is always normal. Usually pre-pubertal, like before puberty, usually it's like called the juvenile pattern. It is usually normal, depending on the clinical setup also. But if suppose if the patient is like 14 years old, patient having exertional syncope, exercise into syncope, not the like when you syncope while standing in the assembly or something. Then you have to suspect ARVs, right ventricular cardiomyopathy, but it's very rare in Sri Lanka. I have not even seen Sri Lankan patient. So what this guy, European, they say they do it, exclude always ARVs, especially exertional syncope. When the patient is running, not after the exertion. Sometimes even after the exertion, they can have vasovagal syncope. And other thing is, I have seen there is 25 years old patient is recently, about a few weeks back, came with ECG, slight T inversion in V1 to V3 and ST depression. Patient referred for that. Actually, the auscultation patient had a pulmonary area flow murmur, and there is fixed splitting, and there's a chest X-ray right ventricular hypertrophy was there. So this patient actually found to have ASD. So actually, clinical diagnosis, so you would first from the history of most patients have unexplained palpitations. So history can't actually tell what is the cause of palpitation. But in auscultation and the ECG, you have to suspect the ECG has right ventricle strain pattern, RV strain. Not the RV, patient had a RA-RV dilatation and AST. So patient will need right heart catheterization and AST closure if recommended. But it's always not normal. We discussed about the MI and heart failure management, but not detail. If the patient of MI given technically patient develop a cardiac arrest, how to manage? So if the patient develop cardiac arrest, it's a ALS protocol. You have to manage the ALS algorithm. Shockable or unshockable pathway, but since we have given it TNK and the patient has STEMI, so the more likely in-hospital cardiac arrest is in-hospital cardiac arrest. Definitely. So in that case, you may have to prolong resuscitation because patient is likely to recover. There's a likelihood because the cause is obviously we can treatable cause, not an untreatable cause. Especially patient have a VT or VF in the monitor. And if you can take the patient to the cath lab, but the problem is we don't have this mechanical CPR machine. So while doing the cath lab, someone actually have to do cardiac massage while wearing a radioprotective gear. Otherwise, when the patient is not in cardiac arrest, if you do angiogram, it's not going to have good prognosis. And the thing is, when suspect chest pain in a young adult, I discuss, I think, pain management, I discuss ACS management, I didn't go into detail, but I touched it. I discussed with our new identify new onset and old new onset LBB, right? I think I have touched things. Any questions you have? You can put in the chat if you want. I think it we have 1.5 hours, but I can answer. I had to rush to some side because their content is big, but I think you may have understand some. Always check the what is the patient presentation into the account. Like this patient, I have seen several occasions patients are treated like ACS when the patient comes to some other thing. It's not actually happens. You have to diagnose ACS because patient does not come like you can't. I mean, since suppose you guys are in the Zoom and I take a ECG of one of you and ask to do some, see some changes and ask to admit for ACS. It's not going to happen like that. Patient usually have some symptoms. Or even so, suppose the patient has silent MI, but the patient will have uncontrolled diabetes, etc. But a completely normal patient does not come with a ACS like that. If there are no questions, we can stop. You can scan the QR code, but I have not uploaded the QR, the Google Drive folder. I will upload the Google presentation and the relevant documents on the folder, so you can probably tomorrow you can download the presentation and other relevant documents. And if you have other questions, also you can submit via the same Google form link we have shared earlier. Since most of you are in the family physician group, I can answer some of the questions like not for each question, but I will collect the questions and give some answer. Anything you want to clarify?
So it seems we don't have any more questions today. So I think we can wind up. Dr. Neranga, thank you so much. Thank you for accepting our invitation for today's CPD session. And it was so important, and I hope and I want to let you know that we are uploading the recording to the YouTube, so everyone can watch it again and again, because most of the slides and the explanations are really important for us as primary care physicians. So so we can call it a day then. Thank you so much. Thank you, Dr. Neranga.
Thank you. Thank you.
Thank you for the participants as well.